Urethroplasty, first stage, for fistula, diverticulum, or stricture, e.g., Johansson type. Second stage, formation of urethra, including urinary diversion. The physician reconstructs the urethra in 2 stages. In the first stage, the area of the stricture is identified by a catheter and urethroplasty, and its location is marked with ink or dye. The incision is made over the stricture area and targeted tissue is removed. Otherwise, the stricture is opened widely and the normal skin of the male or female is sutured to the edge of the mucosa on each side. In those areas in which mucosa had to be removed, the skin is sutured edge to edge. In the second stage, the physician makes parallel incisions around the defect and continues around the urethral opening both proximally and distally. The lateral skin edges are closed over an indwelling catheter to create a new urethra. The corpora and muscles are closed, respectively, becoming the new urethra structure. Urethroplasty, one-stage reconstruction of male anterior urethra. The physician cuts over the stricture area through the skin, fascia, corpus, and urethra. When the stricture is so severe that the urethral lumen cannot be identified, the physician removes the area involved. Otherwise, the stricture is opened widely and the normal skin is sutured to the edge of the mucosa on each side. In those areas in which the mucosa had to be removed, the skin is sutured edge to edge. Urethroplasty, transpubic or perineal, one stage, for reconstruction or repair of prostatic or membranous urethra. The physician makes an incision into the normal urethra distal to the stricture and opens the stricture on its ventral surface. From here a wide-based skin flap is developed by a U-shaped incision in the scrotum and advanced until it can be approximated to the posterior angle of the perineal incision without tension. The ends of the proximal and distal urethra are connected, anastomosis, to the extremities of the scrotal incision and anchored to the midline of the urethral bed to provide a stable urethral roof. When the urethra stricture has been opened but not excised, the edges of the longitudinal incision in the scrotal flap are sutured to the edges of the urethral wall. The outer edges of the flap are sutured to the edges of the original perineal skin incision. Urethroplasty, two-stage reconstruction or repair of prostatic or membranous urethra, first stage. 53,425 second stage. In the first stage, the physician identifies the injured area using a catheter or a urethroplasty. The incision is made over the injury and carried through the skin, fat, and fascia. If a urethral prolapse is involved, other incisions may be involved. The problem is repaired or excised and layered sutures are made to provide adequate support. A catheter is placed and left for at least 6 to 12 days. In the second stage, to close the urethra, the physician cuts around the urethral defect, using skin from the scrotal flap to make a urethra. The right size urethra must be constructed to allow a catheter and prevent obstructions. The physician pulls the loose skin around the urethra and closes the incisions. Urethroplasty, plastic operation on ureter, e.g., stricture. For the upper or middle third of the ureter, the physician usually makes an incision in the skin of the flank. To access the lower third of the ureter, the physician usually makes a curved lower quadrant incision. The physician inserts a catheter into the ureter to the point of obstruction. The balloon is inflated, sometimes using repeated inflation with increasing diameter of the catheter. The physician incises, trims, and shapes the ureter, using absorbable sutures or soft rubber drains for traction. The physician may insert a slender tube into the ureter to provide support during healing. The physician places a drain tube, bringing it out through a separate stab incision in the skin, and performs a layered closure. Urethroplasty for second stage Hypospadias repair, including urinary diversion, less than 3 cm. Greater than 3 cm. The physician completes the repair of chordee, abnormal curvature of the penis, and hypospadias, an abnormal opening of the urethra on the underside of the penis or on the perineum, by creating a urethral opening in the end of the penis. The urethra is dissected free of the surrounding tissues to mobilize it. A distal urethra, less than 3 cm in 54,308 or greater than 3 cm in 54,312, is formed from the prepuce, foreskin, and an opening is created at or near the tip of the head of the penis. Urine may be diverted by the use of a catheter in the bladder. The skin is closed with sutures. Urethroplasty for second stage Hypospadias repair, including urinary diversion, with free skin graft obtained from site other than genitalia. The physician completes the repair of chordee, abnormal curvature of the penis, and hypospadias, abnormal opening of the urethra on the underside of the penis or on the perineum, by creating a urethral opening in the end of the penis. The urethra is mobilized by dissecting it free from the surrounding tissues. A distal urethra is formed from skin obtained from a site other than the genitalia and sutured to the existing urethra and to an opening created at or near the tip of the head of the penis. Urine may be diverted using a catheter in the bladder. The skin and tissues are closed with fine absorbable sutures. Urethroplasty for third stage hypospadias repair to release penis from scrotum, e.g., third stage sisal repair. The physician completes the repair of chordee, abnormal curvature of the penis, and hypospadias, an abnormal opening of the urethra on the underside of the penis or on the perineum, by separating the temporary attachments sutured between the penis and scrotum during a previous stage of the repair. Urine may be diverted using a catheter in the bladder. The skin is closed with fine sutures. Urethroplasty, reconstruction of female urethra. The physician uses perineal or vaginal tissue to reconstruct the female urethra. With the patient in the lithotomy position and a catheter in the urethra, the physician cuts an inverted U-shaped flap above the urethral meatus and extending on the anterior vaginal wall. This flap is undermined with sharp dissection and spreading of the scissors around the upper portion of the urethral meatus, leaving a strip attached. The flap is sutured into a tube shape, reconstructing the distal urethra. The vaginal wall on each side is brought together in several layers to cover the new urethra. Small submucosal vessels are cauterized and a drain may be placed for 1 to 2 days. Urethroplasty with tubularization of posterior urethra and/or lower bladder for incontinence, e.g., Tenego, Ledbetter procedure. In the Tenego, Ledbetter procedure, the physician elongates the urethra by using bladder musculature. Continence is achieved due to contraction of the bladder musculature. The physician exposes the bladder through a suprapubic incision. The bladder is opened and the bladder neck incision is made 2 cm lateral to the urethra on each side. The musculature is drawn together in a tube and attached to the urethra. The urethral canal is closed in a 2-layer technique. For the Tenego procedure, they are moved laterally.